Ido Weinberg, MD from Massachusetts General Hospital, is going to present the results of the carotid stent fracture issues with the Act I Multicenter Randomized Trial. Dr. Weinberg.
Thank you very much. Good morning, everybody. Thank you for being here and indulging me with your presence, and thank you for the committee for choosing this study for presentation, and I'm truly honored. I took 15 seconds just to tell you how honored I am. So, carotid stent fractures are not associated with death, stroke, myocardial infarction, or restenosis, and this is a sub-analysis of the Act I Multicenter Randomized Trial. Some background. So the rate of carotid artery stent fractures and its association with instant restenosis, neurological events, cardiac events, and death has only been studied in small series, and in fact, most publications are small case series and single center case reports. The objective of this study was to report the stent fracture rate of the exact stent that was used in the Act I study, as well as its association with clinically meaningful adverse events, as well as carotid instant restenosis in this large prospective multi-center trial that was obviously adjudicated by independent core laboratories. The study was funded by Abbott Vascular. So just as a reminder, Act I was a comparison of carotid artery stenting with embolic protection with carotid endarterectomy in patients who were younger than 79 years old, who had a severe carotid artery stenosis, who were asymptomatic, and who were not considered to be at high risk for surgical complications. It says low risk here, but they were standard risk. This is the main result that was published recently in the New England Journal of Medicine from Act I, showing basically equipoise between the two studies when it comes to the primary outcome. And the primary outcome was a composite of death, stroke, and MI in the first 30 days, and stroke in the next 365 days post-procedure. So now to the current analysis. So all patients in Act I were required to undergo duplex ultrasound annually for surveillance of their procedure. After the first 771 patients were enrolled, all subsequent patients were also required to have X-rays of their necks in order to analyze the stents for fractures. All duplex ultrasounds and X-ray images were independently adjudicated by VASCOR, by a vascular core laboratory in Boston. There were overall 822 patients who had both interpretable and comparable duplex ultrasounds and X-rays, and it's about 80.5% of the full cohort. This table shows you a summary of the fractures that were detected. I'll sort of draw your attention to the last row here, where you can see a summary of the overall 5-year fracture rate. There were overall 51 fractures noted. Most of them, as you can see, were grade 1 fractures. For those of you who happen not to know, the fractures are graded from 1 to 5, whereas a grade 1 fracture is when one tine is fractured, and it goes up until a sort of a spiral fracture, which would be a grade 5 fracture. So most fractures here were a grade 1. When we examined patient characteristics and we parsed it out between patients who did and did not have fractures, you will notice that the two groups are quite comparable. One difference that I would like to draw your attention to is that patients who had a previous carotid endarterectomy did tend to have there were more of those patients in the carotid stent fracture group. From an angiographical standpoint, there are several differences that I'd like to point out to you. Mainly that there were more calcifications in the stent fracture subjects, but I would also like to show you that lesion location compared to the bulb. So most lesions were contiguous with the bulb. However, there were more contiguous lesions comparatively in the stent fracture group as compared to the non-fracture group. And finally, as promised, patients with stent fractures, there were more severe calcifications as assessed by the core lab in that group as compared to the non-fracture group. There were no differences in duplex findings between the two groups. And importantly, there was no difference in restenosis between patients who did have a fracture and patients who did not have a fracture. Restenosis was defined as greater than 70% as assessed by ultrasound. And as you can see here, the rates were very similar between the fracture and non-fracture group, and they were not different from a statistical standpoint. The primary outcome, which just to remind you, it's that composite I told you about a minute ago, stent fracture did not affect the primary outcome. Overall, there were 47 such outcomes in the whole cohort, and as you can see, the lines are quite aligned between the fracture and non-fracture group. When you look at the parts of this outcome, so there was no difference also in stroke between the fracture and no fracture group, all the way out to 5 years, I should say. And there was no difference in death between the two groups from a statistical standpoint. And if anything, there were, the incidence of death was lower in the fracture group as compared to the non-fracture group. But again, it did not reach statistical significance. This audience would be interested to know that there was no difference also in clinically driven TLR between patients with a fracture and those without a fracture. I think that's important for this audience, interesting probably for this audience to note. I would like to acknowledge a couple of limitations this study has. So most patients did not have an X-ray available for all time points. In other words, while most of the cohort did have an X-ray and a duplex ultrasound during those 5 years of follow-up, so we were able to use those for comparison. Most patients did not have a comparator for all time points during the 5-year follow-up. And not all patients have not all patients have had a pairable duplex and X-ray. So in summary, carotid stents have a very low fracture rate, as you've seen in this analysis. Of course, more study is needed to evaluate the correlation between stent fracture and pre-existing calcifications or prior carotid endarterectomy. This study was not designed to analyze the causes for stent fracture. It was designed to analyze the clinical associations of stent fractures. But as you've seen, we did see differences between the groups, and that's why I'm mentioning this. Stent fracture is not associated either with restenosis or with clinically important major adverse outcomes. And I think you should note that these results are probably only applicable for the exact stent, which is the stent that was used in Act 1, and further study is required to confirm generalizability of these results to other stent designs. Thank you very much for your attention.
Thanks, Dr. Weinberg. I guess one of the take-homes is we may not have fracture-resistant stents, but we're getting fracture-safe stents. And Josh, you have any questions for Dr. Weinberg?
So, wonderful presentation, Ido. I have to say this is, I think, in my opinion, an incredibly important thing to present. There's an ongoing fear of stent fracture and what it means. And I will note that I find your two bullets on your last slide a bit contradictory. Why do we have to know the mechanism of stent fracture if stent fracture actually isn't causing a problem?
Thank you for the question. So I mainly put it up there because when discussing this study, I think that is the reason for stent fractures is something that people are very interested in. I think it is also something that people are used to discussing from other vascular beds, and for that reason I felt it was important to note, at least as a sort of a nidus for discussion.
Do you think that the stent fracture data in the carotids informs our understanding of stent fractures in other vascular beds, or it's vascular bed specific?
I did put a lot of thought into that prior to this presentation, anticipating such a question, and I have to say that after thinking long and hard, I did not come to a good conclusion. I do think that there are publications from the lower extremities actually showing different types of results than what I've presented, actually showing that there is some association between at least greater levels of fractures and adverse clinical outcomes, so there may be a difference.
For Ken and Misty and Ryan, did these results surprise you at all? What's your take home on this?
I can speak to that just based on prior review experience with carotid stents. I think certainly it's interesting analysis. I think that particularly with some of the earlier carotid stents that were reviewed, which I think would include Exact at the time, there was a good bit of discussion or thought about the relevance of fractures, looking at fracture analyses or what could be some of the predictors of fractures. Even at that time, though, I think we were thinking about the prominence of fractures in carotid arteries to be different than, say, in other vascular beds. And so I think that factored into the study designs, the analyses we expected from it. I think the analysis that was presented here, just personally, was really informative. Certainly, it could maybe go to inform how analyses are done in other vascular beds. I think just together the body of evidence that we continue to collect regarding carotid interventions, things that we can learn about how we can learn about the safety and effectiveness of that is certainly important. So I agree with the good work that was done. Was this a pre-specified analysis in the protocol?
Yes, it was.
That's great.
Hey, Chris, you have 11 seconds. So here's the softball right down the middle. This was the last big remaining concern. that stent fractures, when they occurred, would increase the risk for events. So now that I think we've definitively shown that's not the case, how do you put that in perspective around the whole field of carotid stenting?
I think the body of evidence continues to accumulate in good North American randomized trials. All three of them show that it's, it's essentially equivalent to endarterectomy in appropriately selected patients by good operators. And we know that restenosis is, if anything, less with this, even if there's a fracture. So I think it's just a reassuring point that supplements that, Michael.
Thank you,
Thank you
Ido.
very much.